Good morning, everyone. Thank you very much for joining us. It is 9:30 on Thursday morning, March 25th. This is the Joint Committee on Pandemic and Disaster Preparedness and Senate Committee on Health. Thank you very much to my Senate counterpart, Chair Kehokalole, for allowing us to have this joint hearing. We will be hearing from the Department of Health, and this will be our fourth informational briefing on vaccine distribution and updates. I'm very excited to see that the state of Hawaii has passed the 500,000 mark for vaccines administered, and we are expanding the number of sites that are available, as well as the number of people that are eligible for vaccines. Chair Kehokalole, do you have anything you'd like to add?
Just that I appreciate the chair and the members of the Department of Health for all their hard work, and for joining us today. And thank you, Chair Ichiyama, for allowing us to have this joint briefing again. Mahalo.
Thank you. So with that, I will turn it over to Dr. Libby Char, Department of Health.
Thank you. Good morning, Chair Kehokalole, Chair Ichiyama, and members of the committees. Thanks for the opportunity to update everybody on where we're at with regard to the vaccine effort, and just cover a few other things as well. If I could get the slides up, please. And just to let everybody know that as Chair Ichiyama alluded to, we have administered, as of this morning, 568,376 shots. And those are from the doses that we have access to. There are some additional doses on the federal side. We'll kind of touch on that later, but 568,000 doses through the Department of Health and our partners. So next slide, please. So this slide might look familiar to you. It's been updated, and this shows the percent of the vaccine that has been allocated to each of the 4 counties. As you know, we receive an allotment every week, and then we are allocating it to the counties and to each island, and to all the partners that are participating as well. So the vaccine, for the most part, goes directly to the hospital, or directly to the clinic, or directly to the federally qualified healthcare center from the allotment that we get. So starting in the bottom right for Hawaii Island, they have about 14% of their population. 14% of the population of the state that's 16 and older. And the reason we use that cutoff is that's the cutoff for vaccination at this point in time. And so they've received the dark brown number, they've received about 14% of the allocation. So that matches pretty well. For Maui, 11% of the population, they've received 10% of the vaccine for Maui Island. Lanai, Molokai, you can see the numbers there. Oahu, 69% of the population and 69% of the vaccine. And for Kauai, 5% of the population, 7% of the vaccine. I just wanted to touch on Maui because that was a question previously, and I think it's, for the most part, caught up. But there were some questions about why Maui's allocation was a little bit lower. And initially, they weren't administering as many doses, but they really caught up very quickly. They've got a lot of partners in place, and they're doing a lot now. They also got some additional assistance to help with some of the non-medical tasks so that they can administer more shots. We have, I think it's about 10 data entry people that we requested from the federal side to come down and help. And so that's helped before. There was a bit of a data lag of getting information into VAMS, and that's been resolved. And thank you to the federal partners for helping with that. And then additionally, we have some National Guard personnel assisting with vaccination. So once again, thanks to the National Guard for partnering with us. And also we have somebody from, I think his primary job is with the DLNR, but he's been helping to provide a lot of the planning and IMT support. So thanks to Lance and his team. They've also made a really big difference in helping to keep things really organized. There's some complexity in allocating the vaccine, and we're trying to make sure that we're allocating a good amount of vaccine to every county. It's a combination of Pfizer and Moderna, and now that also includes a little bit of Johnson & Johnson. And just to digress for a moment, we got an initial allotment on February 28th of 11,900 doses. And then the following weeks, intervening weeks, we really didn't have much of anything, maybe 1,000 doses here and there. But good news is that we're hearing that 8,400 doses will be available to us to order for next week. So we're really excited about that, and we look forward to getting that. Seems to be a really big demand for it here. So we're very, very optimistic because that will help. And we just need to make sure that we're sending the necessary amount of the right vaccine for second doses at the correct intervals, whether it's 3 weeks after your first Pfizer shot or 4 weeks after your first Moderna shot. So next slide, please. So thanks. Josh Quint is one of the epidemiologists with the Department of Health, and he's going to help us to cover the next few slides. So Josh, if you would, please.
Great. Good morning, everyone. So we can, in addition to looking at the allotments and percent progress at the county level, we can look at some of these additional demographic factors and characteristics, including age and race ethnicity. So this slide shows the distribution of the over 75 population, since that was one of the earliest target groups. And we can see by each county, the light green line shows the percent that of that county's over 75 population that has received at least one dose. And then the dark green line will fill in over time as people get their second dose. Or if it's a Johnson & Johnson, then a single dose would count as both initiating and completing their vaccination series. We can look at further age grouping. So after the 75 and older group has mostly been vaccinated, we're going to be looking down to some of the younger age groups. So we can look at the 60 and older and see that they're beginning to make progress as well. And that 60 and older in this case would include everyone over 60. So it's inclusive of the group that's on the left. This is something we'll build out over time as we start to look at more specific age groupings and different intervals and make those groupings exclusive. And then finally, we can also consider the group that's under 60 years of age, because we know that age is not the only criteria where people can become eligible for vaccination based on their employment. And so about half of the vaccines in the state have gone to persons under the age of 60, but persons over the age of 60 represent 24% of the state's population. So we can see from this that the over 60 population has had a preferential access to the vaccine at a higher rate, but we are making progress as well on vaccinating our essential worker population. And then a couple notes to point out some limitations in the data on the left, and particularly this affects our estimation of progress towards the total over 75 population, which is that this only reflects doses that are entered into the VAMS, which is the Vaccine Administration Management System. And so doses that circumvent this process through the federal agencies and federal programs, such as the Program for Long-Term Care Facilities and Nursing Homes, are not required to report into VAMS. And so we estimate somewhere around 10,000 doses are not accounted for in this chart. So those percentages are lower bounds or lower limits on what we know about. Next slide. As I mentioned, in addition to age, we can look at race, ethnicity, and there are also some limitations with this data, but this can give us kind of overview, a quick understanding of how vaccine equity is working out across the state. We can start with just the total vaccine recipient population and break down all vaccine recipients into one of these 5 race ethnicity bins. And so 57% of all vaccine recipients to date have marked Asian as their identification at the time of vaccination. 1% have marked Black, 12% Native Hawaiian or Pacific Islander, 1% any other category, and then 29% white. And then for reference, the gray bars next to them show the state population distributions. Since we know that not everyone in the population is equally eligible for the vaccine, as I mentioned, age and employment status have determined eligibility to this point, we can then subset the vaccine recipient and state population to look at how the vaccine access and progress has gone according to that subpopulation. So if we restrict to just the over 70 population, we can see that 58% of the over 70 vaccine recipients have been Asian, compared to 63% of the states over 70 population are Asian, and then down the line. So one thing to note here would be just that when you look at age as a factor, some of the proportions shift. So for instance, NHPI were 12% of the total recipient population compared to 25% of the state's population on the left. But then when we look at age as an eligibility factor, we see that 8% of vaccine recipients over 70 have been Native Hawaiian or Pacific Islander compared to 11%. So the gap when we consider age is not quite as extreme, but there is still a gap. And then 33% of recipients over 70 have been white compared to just 23% of the state's population. And the next slide, just want to point out a few of the limitations in this data that we are working with. So for one, we would like to be able to report out the data in a more disaggregated way, not having to group all Asians together because we know there are lots of differences within the subpopulations. And same thing with Native Hawaiian Pacific Islander, but we are reliant on the vaccine administration system and how that collects the race ethnicity data at this point. They have added new categories. So in the future, in the very near future, we will be able to break down some of these larger aggregated groups, but because federal standards often dictate data collection, we were limited in the earliest phase. And then, as I mentioned, phase 1A and 1B eligibility was limited to age and employment groups. That's an important factor to consider when thinking about vaccine equity. It is limited by eligibility. These data do not include the Federal Pharmacy Program or Department of Defense doses, so groups that are more represented by those populations will be underrepresented in our data. And then vaccine recipient data in the first iteration of VAMS did actually not include another category. So if someone did not identify with one of the main groupings, they may have left it blank. And so they may appear in some of the missing data, which is about 18%. That's another gap that was addressed with the latest VAMS update to allow both an other category and more specific race ethnicity groupings. And then the definitions of what is included is shown on the right. And then last slide I want to present is just to point out where this information can be found. So all the graphics shown prior to this can be found on our public facing dashboard. It's updated every day on weekdays at noon with refresh numbers. You can get along the bottom, there are menu options and navigation options to be able to dive in and explore on. You can click, so the default view is to see the dose tracking. You can also see the county specific data. You can see age and you can see race ethnicity by clicking the buttons at the bottom, and we'll continue to report and update and add features as we build out our epidemiological analysis. Thank you.
So if we could get Deputy Director of Health, Kathy Ross, to help us just to kind of highlight some of the way the program's going and some of the successes that we've had. Kathy?
Hi, Chair Ichiyama and Chair Keohokahole. Thank you for this opportunity to share information. You know, we've had many, many wins, as you can see highlighted on the slide. As other states made news of what we call angry grandmas and grandpas waiting overnight in the cold to get their shot, we in our state have not experienced this type of angry kupuna spectacle. In fact, we've received and also observed, we've received feedback about the smooth operations at the various pods. And these are pods that are run by government entities like ourselves and the City and County of Honolulu, as well as our private partners that are operating pods. So success there with no long lines or confusion or long hours to get their vaccinations. You know, additionally, CDC has ranked Hawaii consistently in the top 5 to 8 states on doses administered per capita. So that we consider is another really great win. Some of this success can be attributed to our state's approach in prioritizing vaccination eligibility. So recently, the Associated Press did a state-by-state analysis on vaccinations and showed that states like ours, who rolled out vaccinations in a targeted and methodical way, we vaccinated a greater share of our population. For example, even though that it shows that Hawaii had the lowest percentage of the adults eligible for vaccination, which was about 25% at the time of the study, Hawaii actually administered about 42,614 doses per 100,000 adults, which was actually the 8th highest rate in the country. And then, just to, as contrast, when we look at a state like Mississippi, which had the 6th largest percentage of adults eligible for vaccination, they were actually ranked 43rd in the nation for getting shots in arms. So this matches up with the kind of feedback that we've been getting from other jurisdictions when we do our weekly conversations with our counterparts, where they've experienced things where they opened up their vaccinations to a big majority of their adults. And what ended up happening is that they had to cancel a lot of the appointments because the demand just was too great for the amount of vaccines that they had in state, as well as it also made people drive around for hours just thinking that because they were eligible, they should be able to get a vaccination somewhere, even though the vaccine quantities didn't quite meet that need. So they ended up driving all around the state for hours and hours with no success. So, we just want to highlight that sometimes what may seem to make sense in terms of opening it up to the greatest number of people actually proves to not be the right thing to do when you have a limited amount of vaccine available. Additionally, to highlight the successes of our partners and how we have more and more people that are joining in this effort to vaccinate, we have the dialysis entities in our state that will be able to vaccinate their patients. So that's really helpful because dialysis patients will be able to get vaccinated at those dialysis centers versus having to try to go to a pod or a hospital to get vaccinated. And additionally, we will have completed 77 long-term care facility vaccinations as of tomorrow. They will complete their second doses. And so we're very happy about that we're able to get shots to people where they live versus trying to get them to go to a pod as well. Thank you very much.
So this is just a slide, kind of one of the graphics that was from that AP report that Kathy just spoke about. And I think the take home for us was that, this is everybody's first opportunity at doing this massive vaccine rollout. This is unprecedented times. And so there's no playbook that has all the right answers in it, but we've been fairly methodical. I know we've been criticized a fair amount for it. I think we're doing okay, though. This is the approach that we chose, and it seems to be working fairly well for us, for our population. Obviously, it's going to be different for each of the states, but I think we're on track. We're getting vaccine out there. I think we're doing a good job, and then the pace is just going to start picking up faster and faster. So it's coming, and we're going to get people vaccinated sooner than they think. Next slide, please. So this is a slide with the amount of vaccine that we've been getting. And you can see that it's been a steady progression, but there are some bumps here and there that make it a little bit challenging for us. Thankfully, what we're seeing is a slow trend upwards, although we thought it would be a lot faster by now. I think some of it has to do with doses that are being manufactured. Instead of going directly to the states for allocation, it's going to the states through a federal retail pharmacy program. And we'll touch on that briefly, but you can see that we're getting about 68,000 doses per week right now. Next slide, please. So this is where we're at right now. We made the announcement that we were transitioning into phase 1C. It's a huge group. It's like 500,000 people, excuse me. And it's just about half of our residents. This involves 3 different groups: those who are 65 and older, those with chronic medical conditions that put them at higher risk for severe COVID, and those essential workers who are not included in 1A or 1B. And because of the tremendous number of people, we had to sub-prioritize the groups just as we did in phase 1B. Next slide, please. Can you actually go forward one slide and then we'll, no, okay, I'm sorry, that's okay. So if you look at the far left, it's vaccinations in progress, and those are all the people that are eligible to date, and many of those populations we've taken care of the majority of them. So for example, healthcare workers were in 1A, and everybody that has wanted a vaccine is pretty much done. There are a few people that were hesitant at first that are now stepping up, and they're welcome to get vaccinated. As you heard Kathy mention, the long-term care facilities will be finished. Actually, I think today there are 3 more receiving their second doses, and then we'll have gotten through all the long-term care facilities that were part of the federal program. We've been reaching out to the federal care homes, and you can just see the rest of the list there of who has been eligible. And those guys are in progress right now. The middle column is who's eligible to register right now. And so because we had to sub-prioritize, we are now inviting residents 65 and older. And then of the major chronic illnesses, if people are on dialysis, if they're on oxygen because of severe lung or heart disease, they're being asked to please make an appointment and get vaccinated now. And those who are on chemotherapy or other infusion therapies are also being people who have had transplants, they're immune compromised. So we're trying to set up some specific pods for them as well to get vaccinated, and they have been notified. And the essential workers, again, that's a pretty big category. So right off the bat, we're inviting restaurants, hotels, and bars, those employees to please get vaccinated now. And then coming up, there's a bunch more in the essential worker column, and then as well as by the ages. Next slide, please. So there was a little bit of confusion on the essential worker side. The process for getting an appointment now for the essential workers, again, we're focused on those who work in hotels, restaurants, and bars. And we had an online survey that we had for several months. For those who had finished filling out the survey and submitting it, and we had responded, and then they had given a list of employees, we want to honor those lists. Some of them were not 1B, they were 1C, so we hung on to them. And now that we're in 1C, we want to honor them because they did everything they were supposed to. They took all the proper steps. They submitted the information. And so we are processing those surveys and those lists of people and helping to get them scheduled for vaccination. For some of those that went on, filled out the survey, but were never contacted and didn't submit the actual list of names, we're asking that those people just make appointments, those industries and occupations make appointments directly when it's their turn. And the reason is that as we get more vaccine, more pods, we don't need to be as prescriptive. We're transitioning away from the lists. And I think that's going to make it easier for people to just schedule directly. It'll be more convenient for them to schedule directly and make their own appointments. And so that's part of the confusion because there were some lists left, and we just wanted to make sure that we were honoring those while at the same time transitioning away from creating further lists. Next slide, please. So that's essential workers. They can make appointments directly, or for those that had surveys filled out and lists, we're working with them to help them schedule appointments. For those with the underlying medical conditions, this is a very large population. I think the estimate was it was 57% of all adults in our state have at least one of these chronic conditions, which adds up to about 340,000 people. There were a lot of chronic illnesses and conditions that were found to put people at higher risk for severe COVID. And so you can see all the different conditions listed on this page. Logistically, it's very challenging to sub-prioritize which illnesses and the severity of the illnesses in each individual. For example, you have diabetes, but you take a pill every day. You know, maybe I have diabetes and I have to take insulin twice a day and I have to go to dialysis 3 times a week. So it makes it logistically very, very challenging. We convened a group of clinical experts from each county and each of the major healthcare systems. And in looking at the data and trying to help us to figure out how best to approach this, we noted that there was a correlation with these ages with these conditions and age. And so it makes sense that in order to cover all these, rather than listing different illnesses and saying, okay, if you have, diabetes or sickle cell disease, or you've had a solid organ transplant, you're up now. Instead, it makes sense to open the invitation for appointments based on age, and that should correlate pretty well with the underlying medical conditions. Next slide, please. So what we did was, for those 65 and older, you can make an appointment online for almost any pod. In addition, you can make an appointment with CVS or through the Federal Retail Pharmacy Program to any of the participating pharmacies. So you kind of have two choices, and you can just go online, make your appointment yourself, whatever's the most convenient for you, and grab your appointment that way. We also recently have set up calling 211 on Oahu, and that's in partnership with the City and County of Honolulu Elderly Affairs and AUW. So if people need help scheduling appointments, they can call that number and somebody will help them schedule the appointment. And in addition, they can even help with transportation if that's needed. So we're trying to, as best we can, eliminate barriers from people getting vaccinated. On the essential worker side, you can call any of the pods that are available and schedule directly. And in addition, we have a certain pod at Leeward that we're reserving for essential workers to help when employers want to do it as a group. So we're trying to make it as flexible as we can, while also making it a priority for the 65 and older to get it through CVS. Lots of doses out there, lots of access. And for the essential workers, if they need to, we can help them do it through one of the pods at Leeward. As well, the district health offices on each of the counties are partnering with a whole bunch of their community partners to make the vaccine available in a number of ways. What you see on this slide here are some of the main ways that people can schedule appointments. For those who are patients at some of the federally qualified health centers, absolutely contact them, make an appointment, and get vaccinated through your healthcare provider there. These guys are really key because they have access to and relationships with some of the toughest to reach populations, either because of geography or because of culture or any of the other reasons. They're part of these communities. And so they're really key in this whole effort to get vaccine to the people that need it the most. Again, the pods, and those are the hospitals, those are some of the community pods, trying to make available more and more pods, and not just in the urban core. We're trying to add locations out in more rural areas and closer to where people live. So some of those are coming online as well. Even if they're not going to be permanent, they may at least be there for the next month or so. And then the Federal Retail Pharmacy Program, that's a very significant piece of all of this. And we'll touch on that in just a minute. But what that is the federal government has set up a program in every state where they are giving vaccine directly to participating pharmacies. We had no say in which pharmacies. That was determined by the federal government. And the allocation is either Johnson & Johnson or Moderna or Pfizer. And that all of that's being determined by the federal government. We don't have any say in that. But we're glad that a number of pharmacies are participating, and the hope is to just blanket the state with these pharmacies to make it really easy for people to just go to their neighborhood, CVS store, or now I'm hearing some of the Safeway stores are coming online. So pretty soon it'll just blanket the community, and it'll make it very accessible for everybody. They're very familiar with, their local CVS or Safeway or whatever other pharmacies are going to be participating. Next slide, please. So what's the timeline in all of this, and where are we? The state has been getting about 62,000 to now we're up to about 68,000 doses per week. It's not exactly what we had expected. We thought we would be getting a lot more doses a lot quicker, but I think part of it is because we're hearing that somewhere between 10 and 14,000 doses a week are going to the Federal Retail Pharmacy Program. It's good because that means it's in our state and we have access to it, but it makes it tough because it's not vaccine that we can allocate. And in some cases, I think we might be able to use it more effectively and get it out there quicker. So there are trade-offs, but at least the doses are coming in. We will start advancing through the groups faster and faster. And many of those who are in groups that become eligible will have already gotten vaccinated through their work-related eligibility or something else. So it should start moving faster and faster. For example, many in the group with chronic illnesses may have already gotten vaccinated just based on their age. So the question was about, just to mention that the neighbor islands will probably be moving through their age categories much more quickly. We have a slide that will kind of make that a little bit clearer as we progress, but because they have fewer people in that county or living on that island, so it's a smaller population, they'll probably be able to get through the age-based categories a lot quicker. So they're going to probably start moving a lot faster through the categories. I think in the front page of the paper today, there was comment about President Biden and he wants to have vaccine available to everybody by May 1st. So the question is, is that going to happen in Hawaii or not? So the bottom line, I think we're on track if we get a steady supply of vaccine. I want to be cautiously optimistic because if I say we're going to be able to do something, I want to make sure that we really can meet that. So I'm not saying 100% yes, but I'm cautiously optimistic. And just was going through some numbers with the team late last night. So if we're saying that we've already vaccinated 568,000 people, and we have a total of 1.1 million people who are 16 and older in our state, and then we subtract out the 300,000 that are in phase 2, because at that point it's available and open to everybody. That leaves 700,000 people that need to get vaccinated. We know that 200,000 people have already completed their vaccination, so that leaves 500,000. And we know that of that, about 150,000 have already gotten at least one dose. Additionally, we know that the Department of Defense, the VA, the Federal Retail Pharmacy Program has vaccinated thousands. And this is where it's a little bit challenging for us because we don't have good access to that data. So by our estimates, that's probably about 120,000 people at least. And so if we subtract that number out, and we know that we're getting 70,000 doses a week, although some are going to be first dose, some are going to be second dose, we are on track to get through most of the population by about the end of April or beginning of May. So that's that May 1st deadline that we talked about. And then even as we do that, remember that we don't need to vaccinate every last person in a category before we start opening it up to more people. And so I think we will be able to go from 1C to phase 2 pretty close to that time that President Biden wants us to get there on May 1st. I'm very optimistic about that. So again, bottom line, I think we're on track if we receive a steady supply of vaccine. Can I get the next slide, please? Oh yeah, also as we get more Johnson & Johnson, that's gonna make it easier, yeah, because that's gonna be single dose, and then we won't have to use other doses to give second dose. So every one of those doses will complete somebody. So this is just a population breakdown by age, just to show you. For example, if you look at Kauai County and you look at those who are 55 to 64, there's about 10,000 people in that category. And if we're allocating, several thousand doses a week to Kauai, then they should be able to get through that population pretty quickly, as opposed to look at Honolulu, where there's just a lot more people in each of the categories. So we're probably going to see the neighbor islands moving a bit faster from this point forward. We're all moving in the same direction, but we don't want to tie everybody together at the ankle. So we want the counties to be able to get vaccine into people. Next slide, please. So these are just some of the challenges that we're facing right now. You heard me kind of talk about the Federal Retail Pharmacy Program. It's a really good program. We're glad that it's happening, but it does present some challenges for us. As I mentioned, we don't have access to those doses. We don't know when the pharmacies are coming online. We don't know which ones. We don't know how many. We don't know where they're going to be located. We don't know which vaccines they're getting. And so, our local stores have been very good partners. And they've even allowed us to redistribute some of the doses they had when they had allocations of vaccine that they weren't getting through. We pulled it back into the counties and we gave it back to the Kauai District Health Office. We gave some back to the Hawaii County District Health Office for them to use and distribute. Just we're sort of as a community trying to make sure that we're getting the vaccine out to people expeditiously. But it makes a challenge in that we lack data from the federal programs. So while Josh and the team are doing a fabulous job of looking at the data on our end of the doses we control, it's really hard because we don't have visibility on their numbers. As he mentioned, the percent of 75-year-olds that have been vaccinated is above 70% for the most part. We know it's higher than that because we know that on the Fed side, they've also been vaccinating a bunch of people. And in the long-term care facilities, we can make the assumption that a lot of those people are probably kupuna 75 and older. And so we don't have that data back. It makes it a little hard for some of the planning and whatnot. But we know that we're at least at a 75% level. So that's a good thing. Ditto for the DOD, Department of Defense doses that have been administered and those that have been administered through the VA program. We just get aggregate numbers on some of that. We don't get the line item data. So it's really hard to break it down by race or by age. And then the other blue box you see here is just the pairing and scheduling of different vaccines. That's also just been a challenge. And as the complexity, as we go forward and more doses and different kinds of vaccines, it's just a little bit more complex to allocate the vaccines. There are 3 different vaccines now. They have different intervals for second dose. Thankfully, the Johnson & Johnson doesn't need a second dose, but just trying to make sure that when we allocate vaccine, we're pairing first and second doses when we order it for the week. We don't want to mix vaccines at a given site, especially not on the same day, because we're trying to keep things as safe as we possibly can. But to make sure that if we sent you a bunch of Moderna 4 weeks later, we want to make sure that we're covering that with second doses so that people can get their second doses. So it's just a lot of accounting because we are allocating to well over 60 different entities, and we're doing this every single week. Next slide, please. So this, just goes back to the federal retail pharmacy program. I haven't seen a lot of advertising from them, so we just wanted to get the word out that there are numerous retail pharmacy sites now. Again, we have no say in the selection or when they come online, but as far as I can tell, we have about 49 different stores across the state. Some of them are being given Johnson & Johnson by the federal government. Some of them are receiving Moderna and some are receiving Pfizer. So people can register online on their websites. And we also have a link, I believe, on our website, hawaiicovid19.com, that has all the various sites that you can go to get vaccinated. The eligibility should be the same for the entire federal retail pharmacy program for now, and that's senior 65 and up. And then by presidential declaration, they wanted to make sure the education sector could go there as well. It hasn't been as big a deal for us because we made sure that we covered education early on. But absolutely, the education sector is welcome to go there as well. But 49 different stores across the state, more coming online all the time, getting a good amount of vaccine. So it's just going to blanket our state and make it easier and easier for people. Next slide, please. So here's an example of where you can go on Oahu. You can just see how many stores are out there. Next slide, please. And these are the stores on the different islands. And then just recently, the Safeway stores came online. I don't know if they're actually administering vaccine yet or not. Again, this is a program that's happening sort of exclusive to what the Department of Health is doing. And so we don't have a ton of information on them. We're trying our best to communicate with them weekly to share information, but there's a lot of stuff happening that we don't have access to on the information side. But again, they've all been very good partners, and we're trying as a community to get vaccine out there and make it available for everybody. Next slide, please. So Kathy, could you help cover the federal funding side, please?
Sure. So this is our last slide in our presentation, and I want to provide an update to what we talked about in our last info briefing about funding. So as we previously shared, our strategy was to cover vaccination expenses by maximizing the federal funding available to us. So this slide summarizes how the FEMA public assistance funding in the two columns under the orange tab, how that can complement our current CDC cooperative agreements for epidemiology and laboratory capacity and our immunization program. So we reconfigured our two CDC cooperative agreements so that it took into account the approved $174 million FEMA public assistance program. You know, again, just want to give a big shout out to Hawai'i and Budget and Finance and our legal team for helping make this happen. So of the $174 million of public assistance, that covers 100% of eligible vaccination expenses. So again, unlike the previous or the other typical FEMA reimbursements, this is 100% reimbursable expense where we don't have to show 25% state funds being used to get a 75% match from the federal government. Of the 174 million, we have up to $44 million earmarked to cover Department of Health direct expenses for vaccination efforts. So the balance of about $130 million is going to help cover reimbursements that our partners that are doing vaccinations in the community will be able to utilize to, again, cover their expenses. If we see that we're going to max out the $174 million for the current public assistance program, the intent is that our team will apply for another round of FEMA public assistance, which we hope we'll be able to be successful at getting, because that's going to be able to cover expenses of our partners. And then in the far left column under the CDC COAG column, that just in general provides a summary of the different major strategies for responding to COVID-19 and the way that we bucketed our CDC cooperative agreement funds to support those efforts. And lastly, through the governor's office and budget and finance, we're assessing how the ARPA funding might be able to cover things that we originally came in for to request emergency appropriation this fiscal year. So over the next week, hopefully less than a week from now, we'll be able to provide a significantly smaller request for emergency appropriation for this fiscal year. And with that, it ends our presentation. Turn it back over to you. Thank you.
So if I could just summarize, I think we're trying our best to keep things moving smoothly with as little chaos and anxiety as possible. If we move too slowly, people get really frustrated and we have vaccine that's waiting for arms. If we open things up indiscriminately, we get too many people competing for appointments at the same time, and that leads to a lot of anxiety and panic. And if people don't make appointments, we end up with long lines, people waiting for hours, either not enough shots for everyone in line, or we end up wasting doses. So we're trying to balance all of that and make vaccine available and move fast enough that we keep the uptake of appointments as brisk as we can. We will get vaccine to everybody that wants it. And I would just like to remind people of that. We're going to start moving faster and faster as more of the population is done. And we need to remember that in the meantime, we need to wear our masks. We still need to wear masks, even if you get vaccinated. We've had a couple of cases of people who got completely vaccinated and ended up with COVID afterwards. And that's okay. We know that nothing's 100%. It's within the expected range. But just a reminder that you still can get COVID. Thankfully, the vaccines are doing what they're supposed to, so that if you do get COVID, it's not as severe, or it may even be asymptomatic. And that's the whole goal, right, of the vaccine, is that we limit the amount of severe illness or people needing hospitalization or dying from this. So continue to wear your mask, avoid large gatherings, get vaccinated. It's another layer of protection. And please don't let your guard down yet. We're not out of this yet. If you look at the numbers today, we have 122 new cases in our state. We had been, hovering in the 70s, 80s range. We're up to 122 new cases today. So I think some of that's a reflection of, just all the activity that's been going on in the community. So please, please, please don't let your guard down yet. We will all get through this together. If you would like more information, please go hit our website, hawaiicovid19.com. So thank you, chairs, for the opportunity to update the community, and we're happy to take any questions.
Thank you very much, Dr. Char and your team, for that very informative presentation. I'll turn it over to Senate Health Committee, see if they have any questions first.
Members, any questions? Okay, seeing none, I have a question then. Dr. Char, can you give us an update on the variants, on their prevalence in Hawaii, and on the latest information that you might have on their on the differences that we should be expecting, and the impact that the new information you might have has made on our pandemic planning efforts?
Thanks, Chair. Yeah, that's a really good question. So everybody's been hearing about variants, and just to let you know, as time goes on, we expect to see variants. This is a coronavirus, and they are notorious for changing really quickly. To date, my understanding is that with the B1351, that's the South African variant, I think there are, I want to say, maybe about 7 cases that we have identified in our state now. Josh Quint, feel free to jump in if you have more accurate information. And then with regard to the B117, which is often called the UK variant, I think there have been about 3 cases added to our counts. The reason that we care about the variants is that some of them are more transmissible. They're easier to spread person to person than the native COVID. And additionally, some of them seem to be resistant to some of the treatment that we have, some of the monoclonal antibody therapy that we give people who get sick. Some of these variants, if you have a COVID variant, it seems to not work as well when we give you some of those therapies. And then also there's concern that some of the variants, when we vaccinate someone, it creates neutralizing antibodies in your system. And so some of these variants kind of tamp that level down. Thankfully, with the vaccines that we are using in our community, the Moderna, the Pfizer, and the Johnson & Johnson, even if it kind of tamps that down, the amount of immune response that you get is still far more than adequate for you to be protected. So far, so good. But the way the variants occur is through mutations. And in order for the mutations to happen, it means somebody got infected and it got into you, and then it was able to mutate and be passed on. So really the key is that we know how to prevent this, and the fewer people in our community that get infected, the less opportunity for mutation. And we know that by wearing our masks and keeping our distance, that's going to protect us more than anything. If I never come into contact with you, even if you have a variant, I'm not going to get it from you. So that's really, really key. And that's why we keep harping on wear your mask and keep your distance, because the fewer people that get infected, the less mutation, the less variants we will see.
House members in room 309, questions? Representative Wildberger.
Thank you very much, Chair. Dr. Char, would you please address Maui's, as of Monday, 3.2 positivity rate and what the DOH might be doing to help bring those numbers down?
Sure. So let me pull up some of my notes on the numbers. So as of Monday, it was a 3.2 positivity rate. And what that is the percent of all the tests that are done that are positive. And that's on I think that's on a 7-day average. I believe it's down to 2.7% today. Some of that has to do with if we're testing heavily in an area where we know there's a lot of disease, that will make that percent positivity higher. I think it's a combination of making sure we're testing enough. Certainly we don't want to see it above 5%. So we're still well below the 5%. And some of it is probably related to testing in areas where we know that there are cases. That coupled with the overall number of COVID cases is another thing that we look at. So I think we know that there is widespread community spread on Oahu, and also there's community spread on Maui. And so I think that the numbers themselves are okay. We're definitely watching it, trying to get more testing out there so that we can pick up on cases early. And I think to your point, it's really important that we not drop our guard and just focus on vaccine, that we still need to be really diligent about making sure that we're testing people, that we're doing good contact tracing, and that when we need to pull people out and give them a safe place to quarantine, that we have that available.
Thank you, Chair.
Turn it back over to the Senate.
Senate members, questions? Senator Moriwaki.
Okay.
There you
Can you hear
go.
me?
Yes.
I thank you, Dr. Char. Thank you for all the hard work you folks are doing. I just have a question because some of my constituents are concerned that even taking the vaccine, you can get infected. And has there been enough experience in those who've taken the vaccine and when they have been infected, whether, what the impact of that is? Are you less likely to have to be hospitalized? Is the reaction less severe as if you had not had the vaccine? Is there enough experience to give us any information on that?
Thanks. That's a great question on the overall vaccine. So just to be clear, when you get the vaccine, you don't get COVID from the vaccine itself. It's not a live vaccine. So you're not getting sick from the vaccine itself. It's not 100% protective. So a certain amount, a very low percentage of people that get fully vaccinated will still be susceptible to getting an infection. Again, we know of one or two cases locally where that has happened. The good thing is that in those people that were infected, in one of the cases, the person was asymptomatic, and it was just detected when they took a test for other reasons. And so lo and behold, they were positive, but they were asymptomatic. I think others, and some of this is just from really large clinical trials that are done to see the safety and efficacy of the vaccine. Others who did test positive after they had been fully vaccinated, the symptoms are mild or they're asymptomatic. It wasn't as severe as other cases that we see where people got super sick and ended up in the hospital, or ended up in the ICU or anything like that. So I think in the studies that they did, nobody died after they had been vaccinated, and the amount of people that needed to go to the hospital or be admitted to the ICU was significantly lower. So we know that that's really what this vaccine does for you in terms of protection. It's not a free pass to do whatever you want and don't worry about it, ever getting sick or anything, but it really helps prevent serious illness and hospitalization and death.
Thank you. Thank you, Chair.
Thank you.
Dr. Char, to follow up on that question, there's been a lot of interest in the public for some kind of vaccine passport. But given what you just said about someone who was fully vaccinated and was fortunately asymptomatic, but still COVID positive, I'm wondering your thoughts about such a program and public safety impacts, as well as some of the implementation challenges.
Yeah, thank you. That's been a topic of great discussion. This current CDC guidance for travel is that at this point in the pandemic, do not travel. It's safer to stay home and travel only if it's essential. That being said, we know that people are traveling and they're clamoring for it. We know that the vaccine is another layer of protection, but that's in conjunction with wearing masks and trying to distance and all that. We have been discussing the possibility of some sort of travel program, and this comes under the under HAIMA and General Hara, but some sort of travel program where if you've been vaccinated, you know, is there some way that we could alter the exemption from quarantine? I think the challenge right now is trying to have a mechanism where we can validate that somebody has been vaccinated. The governor spoke with our federal counterparts to see about a program, you know, sort of like TSA pre-check or something where you could register and get some sort of designation that you had been vaccinated there and have it validated. We're in conversations right now looking at various commercial entities that could help to do that for Hawaii, to create some sort of passport system where they could validate in conjunction with some sort of registry that a person in Hawaii had been vaccinated. And if we could do that, would that then allow us to, you know, travel locally? At least the local residents would have a means of saying, yes, I've been validated, and to, I'm sorry, yes, I've been vaccinated, and to validate that. Would that allow us to allow people to be exempt from having to do the pre-travel testing and quarantining and all of that? So that is definitely being looked at. I don't have an answer for you today, but there are several people that are looking at that, and we've been having conversations with some of the private companies and really just trying to figure out a way to validate that. But I think at some point it will come. There's a lot of optimism and there's a lot of work going into that.
And just a quick follow-up to that. You know, I'm wondering how long such a program would be practical. You know, considering in a few months, if we're able to meet President Biden's goal of having a vaccine available for anybody who wants one come May, right? Does it sort of make this idea of a vaccine passport almost moot, I guess?
Yeah, those are really good questions, and there are a lot of those questions that we're having conversations with our federal partners and also just with our colleagues in other states. I think the DOC-D folks are definitely having conversations with, you know, their counterparts and also the folks at the CDC, because that does become the question, right? If we can achieve herd immunity, or if we have enough people that are vaccinated so that the risk of becoming severely ill and needing hospitalization goes way down, is that then an acceptable risk for us to be able to, you know, not have people testing quarantine? I think it's a little bit too early in the course of the pandemic and the course of the disease to have good answers for those yet, but it's certainly being looked at, and I know that they're looking at that question and trying to capture the data so that they can do a good analysis of it. Again, the CDC really isn't willing to say anything yet with regards to travel and people who have been vaccinated.
Thank you. I'll turn over to Senate.
Members' questions? Okay, I have a question requested from another member. Dr. Char, can you cover, or I guess, can you discuss whether there is a relationship or correlation between the clusters and positive cases on Maui and trans-Pacific or inter-island travel?
You know, are you talking about Maui Island or Maui County, or?
I think the question is related to Maui Island. I don't have the citation with me now, but I seem to have seen at some point in the last week some information that was reported proposing that there was some sort of correlation. And I think this question is in reference to that, whether in the department you folks are seeing a correlation between the clusters on Maui and travel.
Okay, I'll take a stab at it. I'm definitely not the expert on that. That would be the folks in DOC-D. But from what I do know, I think a lot of the cases on Maui have to do with community spread. I'm not sure in terms of specific numbers of cases from travel, but from what I've been seeing, it looks like the majority of it is community spread. There were several cases tied to people who are living very closely together, just in congregate living situations. one related to the correctional facility, and the other just community housing where there were a lot of people living in pretty close quarters. And I think that accounted for a significant number of cases. I know we worry a lot about travel, but I think at this point, I would be more concerned with tracking down cases related to community spread.
Thank you.
I have a follow-up question to that.
Please go ahead.
Yeah, Dr. Char, regarding the contact tracing, I know when we first started last year, we had to set up the contact tracing system and the staffing and so forth. Are we, do we have a system now? Do we have the procedures for adding people on and shrinking when we don't have as big a need, because now we've got the cases down? How has the Department of Health handled the contact tracing system?
Sure. So as mentioned, Senator, I think we're trying to be very cognizant that we can't just put all of our focus on vaccine, that we still need to be paying attention to testing and to contact tracing and to isolation and quarantine, as well as vaccination. So if we look at the numbers of contact tracers or contact tracing staff, we'll call it that, statewide, I think in February, there are about 313 people. And I think the most recent report that I saw from a few days ago was where we have 308 people. And so there'll be a little bit of flux here and there as people shift duties, because some of them are public health nurses and whatnot, and so their duties will get reassigned. But if something happens, they can, be pulled back to focus on contact tracing. So I think overall, we're making sure that we have a pretty robust system in place with minor fluctuations here and there. But it's been fairly steady. I look at that every week, and it was, 313, and then on February 21st, it was 304, went up to 306 the following week, 308 last week. And then as of a few days ago, it's 308. So I think it's kind of holding steady in about that range. So certainly not saying that we don't need anybody. Let's, reassign everybody and get rid of it. We definitely need to. This is one of those areas where you may have people that are not, full-time, super busy, but need to have people there ready to do it so that we don't fall behind.
I know that during the height of the pandemic, you had help of the National Guard, and part of the effort was to do outreach and have workers in community organizations. Is that network still in place, or how are you making sure that you're into the various rural as well as immigrant communities where you have more likelihood of congregating, and how can you educate and be able to trace should they have become infected?
Yeah, so the National Guard is still very much a part of the contact tracing team, and I think on the DocD side, the disease investigation branch, Emily Roberson had helped with, and the rest of DocD to put together a team of within the Department of Health of Pacific Islanders investigators, very aware that education is a key piece of this. Actually, I'm going to call on Josh Quint, because this is really, he's got a lot more expertise in this area, but I know that they've been looking at this and making sure that we have outreach and people who are, multilingual and can address things specifically. So Josh, I don't mean to put you on the spot, but I don't know if you have anything else to add to that.
Yeah, I can comment briefly on just the role of contact tracing, and we have been tracking over time the time to reach cases. I would also highlight the first contact caller system allows us to reach all newly reported cases in a timely manner. And then to speak specifically to the most at-risk populations, we have been monitoring a decrease in the disparities. So while they reached a peak, as is detailed in an equity report on the disparities that we've seen over the course of the pandemic, we are beginning to see some positive effects of this Pacific Islander and Filipino priority group outreach teams, and that their share of cases has decreased over time, in addition to the overall number of cases decreasing. So that particular program seems to have been very effective.
Thank you, Chair.
House members, any other questions? Okay, seeing none, then I'll turn it back over to Senate Chair Keohakawole to close us out.
So thank you very much again, Chair Ichiyama and members of the House, for conducting this joint briefing with us. Thank you very much to Joshua and Dr. Char, Deputy Ross, and everyone at the Department of Health for all your work, and for conducting another one of these briefings with us. I think it's really important. I think we can all agree that it's really important to make sure that there is a proactive communication in each of these phases of the vaccine rollout. And I also think that it's important for you guys to take some credit, which you did today, which I appreciate, and also have some candid conversations about the challenges going forward. We will, I think, reach out to your office for some follow-up on some of the questions. And I think as we proceed into this next phase, we'll have some dialogue about what are some other big ticket community concerns as we head into the final phase of the vaccine rollout that perhaps we can make available for hopefully a phase 2 and final vaccine briefing. So again, thank you very much for all your work, and Chair Ichiyama for conducting the briefing.
Can I just give a quick shout out to there's 3 of us here representing the department, but I just like to remind everybody, this really is a big team effort. And so kudos to the many people at the Department of Health that are working really hard on this. It's a team effort, and our community partners as well. So thank you.
I'll echo Chair Keohakawole's sentiments. Thank you very much, Dr. Chard, to you and your team for being available this morning. Members, with that, we are adjourned.